Hello, everybody. Welcome to part 3 of my YouTube videos on introduction to dermoscopy. Those of you who have not seen my previous videos, this is an ongoing course that training for GPs, AMA GPs and GP trainees, and to kind of build our confidence in the use of dermoscopy. So if you want to appreciate where we are at, you have to go to my previous 2 parts. So my name is Dr. Kwesiapia. I'm a GP with extended role in dermatology. I work in Hertfordshire and also in West Sussex area. Okay, so this part we're going to concentrate on the 2-step algorithm, which is meant to help us in evaluating the dermoscopic features of pigmented lesions. Okay, so that's the 2-step algorithms. The last part we talked about 3-point checklist, which is a triage tool, and this step we're going to talk about 2-step algorithms. So in the 2-step algorithm, the first step and what we of the 2-step is you are either going to check from the dermoscopy of the lesion whether it has diagnostic criteria of melanocytic lesions. If it's got diagnostic criteria of melanocytic lesion. If no, then you have to check if the lesion has got a diagnostic criteria of a seborrheic keratosis. If the answer is no, then you need to check, has the lesion got the diagnostic criteria of a BCC? If the answer is no for that, then you need to think, has this lesion got the diagnostic criteria of a vascular lesion? So it's really trying to, the first step is for you to say melanocytic, yes, you come to second step. Non-melanocytic, is it seborrheic keratosis? Yes. Is it a BCC? Yes. Or is it a vascular lesion? Yes. So this is what the 2-step algorithm helps you with. When we come to the second step, then we'll use different approaches in differentiating between a melanocytic lesion and also a melanoma. So in the second step, when you come there, you're looking at pattern analysis of the individual lesion, which has the melanocytic features. So with the melanocytic features is a pattern within the lesion. Does it give it a diagnostic criteria of a regular nevus, Mescha nevus, or una nevus, or Ritz nevus, or Spitz nevus, or congenital nevus, blue nevus, which are regular. If this pattern analysis shows regular pattern, then you're going to make a diagnosis of a benign lesion. If it's got irregular pattern on your pattern analysis, utilizing any of these above rules, ABCD rules or 7-point checklist or whatever, or pattern, just general pattern analysis, global or local features. If it's irregular, then it's a melanoma. If it's regular, then you're thinking of any of these benign lesions here. Thinking even about that before we move on, benign lesions of this step, I will probably, in GP setting, when you see even a pattern analysis suggestive of a Reed or Spitz nevus, even though it's regular, these lesions in a post-pubertal age person, if it has a Reed or Spitz nevus features, you're still going to treat it as suspicious of a melanoma. Therefore, the bottom line is when you see a Spitz nevus or Reed's nevus, treat it like a suspected melanoma, referring to weak weight. Let the histologist tell you the difference. As a GP, don't mingle with that. Okay, but if you see a Clark nevus, benign melanocytic nevus, a Mesch's nevus, which is a dermal nevus on the face, which is the bulbous in the smooth surface dermal nevus on the face, or the ulnar nevus, which is the pedunculated jelly-like or strawberries looking like nevus on the body. That's a una nevus type. These are all benign nevus, or congenital nevus, or a blue nevus. These are the things that will help you. Even with the blue nevus as well, when the second step has taught you that this is possibly a blue nevus, if you are unsure, because it's a deep nevus in the dermis, that's why it's blue. As we remember my first talk about where the melanin is. If you're unsure and it's unclear from the history from the patient, even though you're confident that this is a blue nevus, you still need to treat it just like the Spitz nevus and refer on a 2-week wait for it to be confirmed by a specialist. So first step, we're going to look at diagnosis criteria of lesions, which are either melanocytic, non-melanocytic, and then we'll go from there. Good. So the first step, standard algorithm for categorizing a lesion as melanocytic or non-melanocytic. That's the first step. So for the diagnostic criteria of a melanocytic lesion, you will have to look at if the lesion has a pigment network. That's first thing. Has the lesion got aggregated globules? Okay, so globules, are there globules in the lesion? Are there streaks in the lesion? So streaks I'll show you pictures of what these terminologies are. Is there a homogeneous blue pigment lesion that you're looking at? Or has it got parallel pattern when you look at lesions from the palmar or plantar surfaces, or the acral surfaces, or volar surfaces, some terminologies use. So acral surfaces. Because if you use this diagnostic criteria, the sensitivity of determining that the lesion is melanocytic, if it has all these features, is about 95.2%, which is quite high. The specificity is about 90%. Okay, so that will help you in the diagnostic criteria. So this is a bit of a descriptive area terms for that. So when we talk about pseudo network or pigmented network, the network is of a brownish interconnected lines over the background of a tan diffuse pigmentation. So the reason why we use that is that one of the feedback of one of my live presentations was about how would this look in a Black and ethnic minority skin. You still have more tan surface, but pigment network will still be the same. The only difference is in the facial skin. You might get what we call a peculiar pigmented pseudo network. So it's kind of a typified by round, equally sized network holes, unlike that fine network that you see in the other part of the skin on dermoscopy. The pseudo network is fine round holes because the holes correspond to the pre-existing follicular ostia where hair follicles would have grown for in the non-facial, non-hair bearing parts of the face. Okay, so that is why you get the pseudo network and not the typical pigment network in there, but it's still uniform. It will have a typical features of a pseudo network there in the irregularities for it to be benign, but in irregularities for it to be suspicious. So that is about the pigment network. So the reason behind the facial changes is because the facial skin lacks the reti ridges, and that's their flat. They have this flat sheet on the pigments. They interrupted by the follicular ostia. So the reti ridges on the reticular dermis, on the papillary dermis, it's seen as flat, and therefore because of these reti ridges, you have a flat surface. So in the dermo-epidermal junction. So this is just a bit about a pigment network, and if the lesion has a pigment network or pseudo network, that is a diagnostic feature for a melanocytic lesion. Okay. Another diagnostic feature of a melanocytic lesion is aggregated globules, and these are rather numerous, various size, more or less clustered, round to oval structures with various shades of brown. It could be gray to black colors, and they should be differentiated for what you get in the multiple blue-gray globules that I described in BCC. So when you see BCCs, when we come there, you should be able to differentiate between blue-gray globules as opposed to the aggregated globules, which are usually brown, gray, black color. The other diagnostic criteria of a melanocytic lesion is streaks, and these have, sometimes used to be called them pseudopods. I use that, or radio streaming in some of my terms, but they are now combining one term, but they are all known as streaks. They are bulbous, often kinked or finger-like projections, usually seen at the edge of the lesion. Okay. And they may arise from either a network of structures, but commonly they don't come from a network, but they might come out from a network of structures, and they might range from various colors from tan to black. Okay, and then the other diagnostic criteria of a melanocytic lesion is the homogeneous blue pigment. This is the deep structuralized blue pigmentation, which you find no pigment network, but they have no other distinctive local features. It's just homogeneous blue, deep. Okay, and this is usually kind of pathognomonic of blue nevus. Okay, that's pathognomonic of blue nevus. And then when you come to the acral surfaces on the palms and the soles of the feet, then you can see these melanocytic lesions in the palms and soles of the feet, or the mucosa. You will have these kind of parallel patterns. Okay, the parallel patterns, they follow the sulci and the cristae. So when you see the palms and the feet, you see the sulci and the cristae, or the furrows and ridges. Okay. So furrows or ridges in as you see there, or when you look at it in dermatoglyphics. So in fingerprint terms, when you make a fingerprint, what's print out is the ridges, the furrows is the bits that is not printed out. Okay, so occasionally the pigment arrangement might be at right angles to these structures, because of pressure effect. So you might have either you come by either the fibula or lattice appearance of these parallel patterns, particularly if you look at weight-bearing areas of the sole of the feet, and they might not look that parallel to you in terms of in patterns of the furrows or ridges, but they might have different right angular parallel patterns to it. But I'll show you. We'll appreciate that when we come to in details when we talk about acral surfaces. Okay, so these 5 criteria are all criteria of melanocytic lesions. So if a lesion has a pigment network or pseudo network, if it's from the face, has aggregated globules, has streaks, has homogeneous blue pigment, or has parallel patterns, this lesion is a melanocytic lesion. So in the first step, in a 2-point algorithm, from the first step, if it fulfills this criteria, then your answer is yes, this is a melanocytic lesion. Then you go to the second step. Okay, then in the second step, you are going to distinguish whether this criteria, whether is regular is in a regular pattern or an irregular pattern. Therefore, is it a benign melanocytic nevus or a melanoma? So that is a whole idea. But the first step is, has it got a criteria, all 5 criteria? If yes, then is a melanocytic lesion. Okay, so we'll come to the second step later on. So this is just for you to do that. Then when you have clarify how these melanocytes and melanomas are distributed. This is how you see in the melanocytic lesion. So the distribution that the previous diagram or table that I showed you, this is the explanation of this. The melanocytes most fundamentally exist and increase in the basal layer of the epidermis. Okay, so when you're looking at dermoscopy patterns of the network or the parallel pattern, this is what you're looking at, the melanocytes and where they exist within the structure. And if it has any of those 5 criteria that I've mentioned in the previous slide, then you're talking about a melanocytic lesions. So the 5 criteria I'm going to show you A to E. So the melanocytes at the dermo-epidermal junction or the upper dermis have a globular pattern. So the aggregated globules that we'll see will come up in the next slide. They are because of the aggregation of the melanocytes at the dermo-epidermal junction. If you go back to my first part of the series where I showed you the anatomy of the skin and the histology, we showed you the basal layer of the epidermis, which is adjacent to the papillary dermis, and that's where the dermo-epidermal junction is, or upper dermis, where you have some globules there. Okay, and they can be of brown to blue-gray color. Okay, so that is the globular aggregated globules in the melanocytic lesions. Now, I did mention again about the blue nevus. These are aggregated melanin in kind of in the deep dermis, which shows this homogeneous pigment, and that is the pathognomic features of a blue nevus. That is also a melanocytic criteria. And again, when you have a rapidly growing melanocytes in a Spitz nevus or a melanoma, they usually expand mainly at the dermo-epidermal junction. And when the expansion is visible within the dermoscopy, it shows the starburst pattern or the streaks, the projections, the finger-like projection at the peripheries of the lesion, and that is what the starburst or Spitz, pigmented Spitz nevus will look like. There is a Spitz nevus in children, which is usually there has a dots in there, and it's different from the Spitz nevus also, or nevus of Reed in an adult, which is still another type of Spitzoid nevus, which has a starburst appearance. Always, I go back as a GP to understand that when you see streaks, when you even see a starburst appearance, when your dermoscopy still gives you an assurance that this is a Spitz nevus, it's got a diagnostic criteria of melanocytic nevus, because of the way Spitz nevus behave, difficult to distinguish them dermoscopically from melanoma. Therefore, in a post-pubertal patient, I will never stop emphasizing this. When you see a starburst appearance or kind of a Spitz nevus-like stuff, you need to refer 2-week wait. Okay, that's the safety thing for you as a GP. So this is the kind of the image of the description that I was showing you from the previous slides, and this is what a regular pigment network looks like. This is a schematic drawing of a pigment network, and you have this brown area of the network there, and it's quite uniform. Aggregated globules is like these dots that you see on dermoscopy. These are what we call the aggregated globules. So these are the dots, and they should be uniform and regular for it to be benign, and irregular for you to, when you come to the pattern analysis on how these aggregated globules look. And I talked about the branch streaks, so could be either pseudoports like this. It could be multiple straight ports like this, or just a single. And this is how you look like in a Spitz nevus. This is described as a starburst appearance, like a star. It's got the projection at the edge of the periphery. So starburst appearance, branch streaks, and again, and then the other diagnostic criteria of a melanocytic lesion is this homogeneous blue pigment, which is a deep melanin in the deep dermis, which will look like this in a blue nevus. Okay, and then when we talk about the third diagnostic criteria, sorry, the fifth diagnostic criteria of a melanocytic lesion is a parallel pattern which you see in this acral surface. This is either the palm or the sole of the feet. These are all melanocytic criteria. Okay, so again, the structures of the face. It's really important to understand this melanocytic, the diagnostic criteria of melanocytic nevus. The structures of the face, facial skin, as I explained, because of sun damage, and the dermal, papillary, and retinal ridges are both effaced in varying degree, and as a result of that, you get the pseudo network, which is this is what you see here. So you see all these areas of the pale concentric areas in the middle. These are the what would have been filled by the hair follicles or follicular ostia, and therefore it looks like a pseudo network. Okay, so pseudo network. So this will also have a similar feature of similar look of what you get in a solar lentigo. In fact, it's very difficult to distinguish between a solar lentigo and just a normal melanocytic nevus on this face, because of the way they look on dermoscopy. In fact, most people use them interchangeably, that if you see a mole on the face, most likely is melanocytic nevus or solar lentigo, and again, you know, you can actually distinguish between the regularities when you look deeply at the network, whether it is a melanoma in situ when we come to pattern analysis. So as I said, the pattern shows the proliferation of melanocytes at the dermal-epidermal junction because of the flattening of the retinal ridges, and this is what you see. Is this like lentigo pattern growth of nevi or solar lentigo on the face, and it can be also melanomas on the face depending on the distribution of the pigment what you see on the face. We'll come to that in details when we want to do the second step, where we want to distinguish between melanocytic features and the melanoma. This time we're just doing that step one, first step. Okay. So the second other criteria that we will be looking at for in the first step is whether the lesion has got a diagnostic criteria for seborrheic keratosis. Okay, so in the first step, again, you want to see, has the lesion got a diagnostic criteria for seborrheic keratosis? So in seborrheic keratosis, the criteria you're looking for is, has this lesion got light brown figure-like structures or curved lines? These light brown network pattern of finger-like structures is one criteria for seborrheic keratosis. That's one. That's a positive criteria. Has this lesion got a cerebriform pattern? Cerebri as in the brain. Does it look like the brain? Fissures and ridges on the brain, in the dark brown furrows pattern, raised or like a brain appearance. This is likely a seborrheic keratosis criteria. The third thing is, has it got a comedone-like openings, which usually will be brown, yellowish to black, brown, brown or black, brown, black, round to ovoid, sharply circumscribed plugs on the ostia of the hair follicle. So when you see a seborrheic keratosis, you see these they are like open comedones, small plaques, comedone plaques, and these are what we call comedone-like openings. Okay, and they when irregular shaped, they can give you this crypt appearance, and they can be or they can give you irregular crypts as well. And so, but these comedone-like openings are all diagnostic criteria of a seborrheic keratosis. And then you have the media-like cyst, which is also often numerous in number, and they might be variable in sizes, but they are kind of yellow, whitish, and rounded structure. And then sometimes they call them yellow clots or white clots and some others. But the good thing about this is, remember in my first video, I talked about using polarized, non-polarized dermoscopy. If you have your dermoscopy and you use non-polarized contact dermoscopy, you appreciate these media cysts more. They are more exaggerated when you switch off the polarization on your dermatoscope to look at these lesions, but it has to be contact. Okay, so you can appreciate media-like cysts more, comedone-like openings, cerebriform pattern of fissures, and then these are all part of the diagnostic criteria of a seborrheic keratosis. So we're going to look at these two things, and then when we come to the details, this is what you see, that in seborrheic keratosis, when it's early, it can have this appearance like the solar lentigo with the finger-like projections that we'll talk about, but might be slightly palpable. So most people with seborrheic keratosis on their face very early can start like a solar lentigo, and therefore when you look at the dermoscopy, it's difficult to distinguish between a solar lentigo and an early flat seborrheic keratosis on dermoscopy. They all have the finger-like projections that we describe as a diagnostic criteria. When the finger-like projections are seen at this stage, as mentioned about, in later phases, the seborrheic keratosis begin to change to become like the brain, the cerebriform. So when it start growing and it gets bigger, you get the cerebriform pattern. Then it start getting the fissures, and it start getting the keratinization and the ridges as well. So nearly completed seborrheic keratosis will demonstrate what we call acanthotic changes, where you have all these, the comedone open and the multiple melia cysts, and so it just grows. But just a hyperkeratotic type will only show a very non-specific pattern, especially when you have hyperkeratosis, seborrheic keratosis. It might just be crust. Dry crust might not be very clear, but the pattern, the history can give you, when you look in dermoscopy, can tell you that the lesion you're looking is as seborrheic keratosis. Okay, so this is what the finger-like projections looks like on seborrheic keratosis. The light brown finger-like structures seem to correspond to the epidermal elongation on the basal melanosomes, but with no papillomatous at this stage. So these are kind of a little bit flat, a little bit raised, but they look like finger-like projections. Okay, these are also seen in solar lentigos. So a little bit more about seborrheic keratosis. So as the keratinocytes progressively increase in number, it becomes more papillomatous, and then it becomes more keratinites, and then you get all these fissures and plaques that you see there. So acanthotic changes, decreases, and then you get this horn-like cyst that you get in the seborrheic keratosis, and sometimes you get these comedone-like openings that you see on dermoscopy. So it's really important to understand seborrheic keratosis. You see, majority of 2-week wait referrals to dermatology will be seborrheic keratosis. Okay, and most doctors will describe it as a mole because the patient thinks it's a mole. And your expertise as a GP is after doing some dermoscopy training. You are looking at, this hasn't got any features of a melanocytic lesion as I talked about, but it has all the features I can see of a seborrheic keratosis. It's got finger-like projections, it's got fissures and ridges, it's got comedone-like openings, which are these brown, sharp demarcated areas there, and small different, and then the media-like cysts are the white areas there. So you see the media-like cyst is what I am pointing to on the dermoscopy here. These are white, and then these openings, comedone-like openings, are the brown ones there, these ones. So you can see the gyrator just looks like a brain. Really, if you get confidence in this, that's really going to be helpful in kind of reducing the amount of referrals to weak weight, reassuring the patient of seborrheic keratosis. This is like a dermoscopy image of a seborrheic keratosis. It looks like a brain. Okay, so that is gyrated, and seborrheic keratosis in there. This is another seborrheic keratosis, which you can see the media-like cyst. These are the white areas there, and a comedone-like openings, the brown areas there that I'm pointing to with a pointer. This is a special type of seborrheic keratosis known as melanoacanthoma. It is an intense seborrheic keratosis, and nobody will criticize you if you refer this and as a suspicious melanoma. If the history is not very clear, the reason this is there is an intense seborrheic keratosis, there's intense acanthosis, and therefore it gets a little bit darker. The aggregations of the melanin is much more on the surface, and it's all lumped up together, and towards the the keratinocytes and the dead cells. Therefore, it looks very, very dark. But you can still see the media-like cyst at the edges. You can see a media-like cyst there. There's a media-like cyst there. There's one here. If you look here, there's a media-like cyst there, and you can see the comedone-like openings. And all these areas are comedone-like openings that you can see there. That's what you can see, comedone-like openings there. And there's a bit of scaling on the surface of the skin. In general, I mean, sharp demarcated. You might be worried that, oh God, has he got these pseudopods or nodes? Are they streaks? You're worried about those things. No one will criticize you when you refer this to weak weight. The best news for the patient is histology will come back and say it's not a melanoma, it's a seborrheic keratosis. You all win. Okay. And it's another melanoacanthoma. This one is much more clearer to reassure the patient because it's very well demarcated black seborrheic keratosis. It's well demarcated, but when you see the dermoscopy, you can see the media-like cyst in there. You can see the media-like cyst there, and then the comedone openings is the comedone openings over there, and some of them over here. But this is also a seborrheic keratosis. Okay, occasionally you can have a seborrheic keratosis which is irritated. It can just be caught in either from a trauma, or if people will say get caught in my bra strap and it bleeds. There are other criteria on seborrheic keratosis which, when we come to blood vessels, it will help us in one of the kind of subsequent talks we'll have on blood vessels that you see on dermoscopy. The hairpin blood vessels are also features that you see in seborrheic keratosis. These are hairpin blood vessels, but it's not just seborrheic keratosis that you see these hairpin blood vessels. These are seen in keratinizing tumors. So you can see in seborrheic keratosis, you can see them in warts, you can see them in SCCs, you can see them in keratoacanthomas, So therefore, they are not just features of seborrheic keratosis. That's why there are added features that you can help you with your dermoscopy when it comes to blood vessels. The predominant stuff that you need to be confident about the lesion is not just the vessels, it's the media-like cyst, gyrated, comedo-like opens, history, and this is the stuff that absence of network, it helps you to that. This is a seborrheic keratosis. As I said, yes, hairpin-like vessels and also surrounding halo can be features of keratinizing tumors. Seborrheic keratosis is what SCCs, keratoacantoma. By the way, if you see something suspected of a keratoacantoma, it has to be referred as a 2-week wait. Some well-differentiated SCCs can look like a keratoacantoma. So all keratoacantomas need to be referred as suspected SCC and a 2-week wait. Right, so this is a variant of a seborrheic keratosis, which is known as a clear cell acanthoma. A clear cell acanthoma has a very distinct appearance in the sense that it comes usually found majorly in men and extremities in the trunks, but it has dermoscopically, it has a dotted blood vessels, which has a pattern of a necklace of pearls or network of pearls. And that is just a pathonomic this dermoscopic feature, which helps you to say that this lesion is a clear cell acanthoma. It also has the other features of seborrheic keratosis. You can see the media-like cyst there. It might not have any comedo-like opens, but it's got media-like cyst there. There's some media-like cyst there, and then the network of the pearl distribution of the blood vessels as well is what tells you that this is a clear cell acanthoma. Media-like cyst tells you is a variant of seborrheic keratosis, but this is specifically pathognomic of clear cell acanthoma. Fantastic. So I'm going to end here. We're going to go to the next part in the next video, where we will be looking at other diagnostic criteria of other lesions, and hopefully you'll be able to absorb that. So we're still on the two-step algorithms, but see you soon in part 4.